letter that we work with here as medical doctors and physician assistants. We've discussed the components. We have discussed the inefficiency associated with that referral letter. Now we're going to look at the HEMA component, how we doctors contribute towards that inefficiency. So Dr. Akins will take that.
Right. Yeah, so the human beings are part of that system.
Exactly.
And we also have our parts that we play that make the referral system very difficult and inefficient. So from my personal experience, one issue I have noticed, especially whilst I was at the district doing my rotation, is that you always find that you have all these weird cases being referred to you. I mean, when you are just about to get to the weekend, or when there's about to be a holiday, right? So some of these cases don't necessarily have to be referred. They just need to be detained and monitored. Exactly. You just do something and let the person go home, okay? He doesn't need to be referred and carried to another hospital, My hospital was actually, even though it wasn't designated a district hospital there, it's a Catholic facility, and it's very good. And so it's basically serving as the district hospital in that facility, and it's covering like a wide area there, and everybody is coming there. So that place is like the Kolebu of that place, I'm telling you.
Wow.
So apparently some of the hospitals that are close by, patients just get to the gate, and then the gate man will tell them that they should come to my place. Because it's like they haven't even been seen by a doctor over there. Yeah. And then some of them actually go in, be seen by a doctor and healthcare professional, and then they write a referral letter, and then the letter comes, and then the referring diagnosis, you're like, wait, so if it's actually what you think this patient has, this patient doesn't need to be here, it doesn't have to come here for anything. You could have just done this, that, and that, and this patient will be fine and go back home. But they don't want to keep patients because they need to go home, and they don't want anybody calling them to come and see any case. When you now end up pushing cases to other people, that's why other people get overburdened. Yeah. And frustrations come in. Okay, you get it. And so now when people kind of detect or feel that that is what you are doing. So when they're referring a case to them, you call, they'll say
they're resistant.
Yeah. You don't have to bring this patient here. The issue with sending the patient for a referral when they don't need it is that first of all, you're going to cause, this person comes from your community. His house is just 2 minutes away from your hospital. They can easily go home and bath. Family can bring things, food and all of that. It's so convenient. Yeah. Now you've shipped this patient miles down to another place when they didn't have to go there. So much inconvenience, cost involved. They are going to start the whole process. It's unnecessary. So sometimes we need to know which cases we shouldn't refer, and we need to apply ourselves to manage these cases. Now, having said that, the opposite spectrum of that comes in where you have just kept a case and you keep doing all sort of maneuvers, all sort of concoctions, all sort of regimens just to keep the patient in your facility, because you know that every day they lie on your bed, you are going to make money. Meanwhile, the patient is not improving, it's deteriorating. You probably don't even know what's wrong with the patient, but you're just throwing one antibiotics over the other, and this over the other, and you're like, why? You could have just referred this patient to be seen by a specialist. You need to know when it's beyond your capability. One thing that makes someone a good surgeon is knowing when not to go in.
Yes, that's very true.
Because anybody can go in. Anybody can just see a case. Let's go in. But knowing when not to go in is what makes you a good surgeon. And I think that applies even to internal medicine or every other field in medicine. You should know when this is beyond your limits. Okay, the Hippocratic Oath would say that do no harm. Okay, do no harm, yeah. The thing is beyond. It has nothing to do with your ego. If you don't know, you don't know. Like when it comes to a patient who is critically ill under your care, if you don't know, you don't know. It's time sensitive. Send the patient out to the specialist. Don't keep the patient and keep doing all sort of investigation. If you don't even have MRI in your facility, and the patient needs MRI, it means that whatever is probably wrong with this patient, you can't manage at your facility. You can't ask the patient to go and do the MRI in Accra and come back to your mushroom hospital or facility for what? Like whatever the patient has.
It will see and say, please go away.
Yes, like whatever the patient has, chances are you can't manage at your facility.
Exactly.
So if it needs an MRI to diagnose, chances are you can't manage it there. So you refer for the specialist to see. You don't have to go and do an MRI for 5,000 Ghana cedis and come to your facility, come and sleep there for 2 more days, and you throw all sort of things, and then later on you now refer. Now, when you delay and you refer at very late hours, when complications are probably set in, now they get to the referring facility, the specialist sees and say, oh, this is advanced, or this is too late, and patient died at the referral facility, the receiving facility. And now it becomes a mortality at the receiving facility. And at the end of the day, they were like, oh, whenever we send a patient to this place, they always die. And now it creates this perception in the whole community. Everybody starts thinking that, oh, this facility, whenever you go, people die. And so when you're referring patients there, they don't want to go. I mean, I know we have a whole episode on this referral stigma, but these are some of the things that create some of these stigmas. In as much as you should know what cases you should manage and not refer, you should know what cases you shouldn't manage and should refer. Like you should be able to make that binary classification. Like, I classify this case as a case I can manage. I classify this case as a case I should be able to manage. Guidelines should be there. I mean, everybody should know how to manage malaria. I mean, unless there are like some complications like AKI and things like that. Or
cerebral malaria and those things.
But like a simple uncomplicated malaria, you can't repair. I mean, really, then right. So there are some cases that you should know how to manage. But there are some cases, as soon as you diagnose, you should be able to diagnose. That's the first point. You should be able to diagnose, and as soon as you make the diagnosis, the patient is out of your facility. You diagnose nephrotic syndrome, you don't keep it. Yeah, we all know nephrotic syndrome. Most of them are steroid sensitive. You can try steroids. Probably when they go to a referral facility, I mean, the specialist who do steroid and all of that. But you don't sit in your village and decide to start steroids. Before you start steroids, there are a whole bunch of investigations you have to do before you can start this patient on steroids. You're just going through the person on steroids. Probably had some cops.
But here it seems it seems I'm not cutting it off. It seems like that's the standard, because most of the nephrotic syndrome cases have actually received referral at Children's Hospital. Like, they come, they're already on steroids.
Right.
Like,
who started you on steroids?
You're not a specialist.
You're not a specialist. So you see, and so now they keep this patient and keep trying all these things, and like two months down the line, they are seeing no response, and then they now push to a specialist. By which point, patient has actually probably also developed other complications related to steroids and all of that. Yeah. So the point here is that you should know what cases you should be able to manage, and the cases that you shouldn't be able to manage, or the cases you shouldn't even attempt to manage. The other part is knowing where to send these patients. You know, now that you've now made a diagnosis, where do I send this patient? Where are the nephrologists? Where are the neurologists? Where are the neurosurgeons? Yeah, me, for instance, I was training Kolebu, so I immediately, when I see a case, oh, Kolebu. Oh, Kolebu. I mean, Kolebu has everybody, right? All the specialists are at Kolebu. And that probably happened with most people. You know, they tend to go to that default place that they know. But it's only in Kolebu that has all these specialists. The other hospitals have all these specialists, and even some that Kolebu doesn't even have. I think I spoke about the referral guidelines that we have, which is provided by the Ministry of Health. It's actually available on their site. When you go to their downloadables, you see that there. It's actually very old, and it needs to be revised. It's dated like 2012. But inside that guideline, they actually set something about, you know, a document that is going to contain various hospitals and the services that they provide, and I mean, it's called the Directory of Services. And so this document is supposed to be made available to all hospitals in Ghana, and so that when you want to refer a patient, you can just pick this book, go through and see the hospitals that have the services that you want, and you can easily refer. But now we don't have that. So it's just based on what I know. It's hearsay. But then your default is always to go to the place you know. You know, and where you've been. You see, but this information should be made available to everybody. You don't have to be training. You see, when you have this document which is standardized and is available to everybody, irrespective of wherever you were trained or wherever you've worked before or whoever you are working with or whatever they know, that book is available for everybody to refer to. It's a reference guide. Everybody can open it and use. So that's the issue. We don't know where to refer cases to. The other one I would say will probably have to do with, you know, not explaining much to the patient why you are referring them and why they have to go. Yeah. You see, I mean, you are the one seeing them. Okay, so you know why they have to go. They don't know. They have a lot of stigmas about referrals. Some people don't even know what a referral is. Those who know immediately probably have had some experience, or they've heard some things, already have some stigmatas around that. And so as soon as you are referring them and you mention some particular facilities, they start crying. They don't want to go. And some of them actually get
sentence.
pissed,
Yeah.
like especially the relatives. They are like, "Why are you referring my mother to this place? Are you also a doctor? Like, why are you pushing out?" Like, so in their mind, they think you are this lazy guy who doesn't want to take care of their mother, or you have some personal grudge or something. No, but
yeah,
you
especially
see,
if you're not
if you don't
explaining.
if you don't explain to them, I mean, of course, I mean, they are allowed to think anyhow in any way. But I think one thing is we need to sit, patient down, patient their relatives down, tell them why you are referring a patient to a particular facility and why you are not keeping at your facility. I mean, for instance, I had an encounter like that with a patient back here in Accra when I was in a locum at some facility. The nurse called me to come and see a patient that was brought into the ER. I think it was like 70-something-year-old woman. He had a whole bunch of chronic conditions, diabetes, hypertension, and she was also being managed for chronic kidney disease at Kolebu. And so the kids, they are all working, they go and come, go and come. They don't really stay with her, but they all try to visit us often. And so they only went to the evening to visit her, only to find out that she was unconscious. And they brought her in. They didn't know what transpired and all of that. But when they brought her in, well, she had regained some level of consciousness. I mean, the past medical history and all the risk factors and the physical signs and all of that. I suspected she had a CVA, a stroke. And so immediately I said this case would not, the best place to manage this patient is a place that they can do a CT scan where a neurologist is there to give her better care. And so whilst I was even still examining, I told them that we need to refer a patient. I started telling the nurses that they should call, give me the number to the nearest specialist facility. At the time, I think UGMC was the nearest to that place, UGMC 37 and all of that, but UGMC was the closest, So after I finished, they were kind of like, you could see from their expression, like, why am I trying to refer? Because they were just like a few minutes away from where they put the patient to.
Yeah.
So to them, it's more convenient if the patient stays here, right? But then I called them to the office and then I spoke with them, the diagnosis, why this patient needs to be pushed out and not here and all of that. And at the end of the day, we all came to an amicable conclusion that, yeah, this is the best place to send this patient to. These are some of the things that the human factors that I have personally encountered. I mean, you also working, in various hospitals. What have been your personal experiences when it comes to these things?
We've actually gone through almost everything, the human factors associated. There are some doctors who will push patients away because they want to have time to do what, like over the weekend, they want to go to a wedding and those stuff. And then you have some facility who will keep patients because they want to kind of like get money and they more time. Yeah, they want to cash out. Yeah, and we don't know, many doctors don't know most of the referring facilities, so they are only conversant with facility that they have been to and they work to, so that's where they kind of like send their patient. And then sometimes too, we don't explain more often to the patient as in why we are referring them. And some people, once you refer to a certain facility, the stigma associated, they start to cry and those things. So for those ones, you sit down on the round table with the relatives and then come up with a solution on which facility we should refer this patient to that will get the same care if they don't want so facility. Kind of like explain everything. So from my portion, I think what needs to be done is to kind of like create this kind of awareness concerning referral guidelines. You did mention that we have a referral guideline, but how many doctors know about that? Even myself, it was just lately I got to know because of our referral application we are developing. So a lot of doctors don't know about the referral guidelines, which cases to refer, which one to hold, a certain facility, a certain medication you're supposed to prescribe. And so there are a whole bunch of things associated with the referral. So that contribute to the human factors that contribute to the inefficiency associated with our referral system. So Akins, I'm really grateful to have you. It's really been wonderful. Watch out for the next episode and we're going to come up with something very interesting. So thank you for the time. If you have any question, if you have any concern or anything you want to discuss further concerning our referral system, I will leave a link below where you can send us an email and then we will go through and then reply you.
Right.
Okay. All right. So